Here's my week's reflection on what antibiotic stewardship means, as well as our roles in this stewardship as healthcare providers. An antibiotic stewardship program uh, is programs and interventions that help ensure that patients get the right antibiotics at the right time for the right duration. Antibiotic stewardships help improve patient care, which in turn shortens hospital stays, um, which in the end benefits patients and hospitals both financially and with their efficiency. Biggest issue with antibiotic therapy today is that 20 to 50% of all antibiotics prescribed in U.S. acute care hospital settings are unnecessary or inappropriate. Um, since antibiotics are drugs or medications, they have the same issues as far as side effects and adverse reactions that other medications have. One of these being C. diff infections. Um, Antibiotics is obviously not just a problem for any one person. It affects many people, especially in a healthcare setting, acute care settings, with MRSA, C. diff. Um, you have the potential to transport these to other patients and have them infected if not using proper precautions. Um, Using universal precautions, make sure you're doing your PPE, washing hands, and everything like that is the biggest thing. Educating family, making sure that they're not coming in and out of rooms, transferring that to individual family members, inside the house, and other people in the waiting areas. Biggest thing, I guess, where I work at too, we deal with patients that come in for outpatient infusions. Generally, the majority of these are antibiotic infusions. We need to make sure that the patients are educated on continuing their program, showing up every day, and adhering to however many days that they need to come for this treatment to not miss any days. Um, those are the biggest things that we can do as healthcare professionals. Not allowing people to just take antibiotics because they're sick and they're borrowing somebody else's antibiotics. May not have enough, might not be the right one. Education is the main thing. Um, the other thing, the first step towards antibiotic stewardship is to promote antibiotic best practices. There were three of these things that included ensuring that all orders have dose, duration, and indications when written, getting cultures before starting antibiotics, which is very important, and taking an antibiotic timeout, which I thought was very similar to like surgical timeouts or any other procedural timeouts, giving you a chance to reassess antibiotics after 2 to 3 days or 48 to 72 hours. The questions that you would ask during this timeout are, does the patient have an infection that will respond to antibiotics, first of all? If so, is the patient on the right antibiotic, dose, route, and administration? Um, if not, can a more targeted antibiotic be used to treat the infection uh, that causes a de-escalation, from a broad spectrum antibiotic down to a more localized antibiotic? And finally, how long should the patient actually receive this antibiotic? Um, so I thought those were very good points there. Uh, According to the Antibiotic Stewardship Driver Program, um, timely and appropriate antibiotic utilization in an acute care setting allows for a decreased incidence of antibiotic-related adverse drug events, which benefits everybody, hospital and patients. Decreased prevalence of antibiotic resistance to healthcare-associated pathogens. Decreased incidence in healthcare-associated C. difficile infection, and decreased pharmacy costs for antibiotics. Um, the next part of our discussion was on the Ebola virus. I know the strain originated from what we read through the Zaire virus. It's mutated multiple times. I've read a report that says it's mutated as many as 300 times. This mutation allows for drugs and vaccines and antibiotics and things of that nature to be very difficult to pin down, since the mutations will not allow the uh, medications that we give to work, and if they do, they're maybe not effective enough, and which could in turn cause it to be more resistant to future antibiotics because it is not killing the actual virus or bacteria or whatever the patient may have at that point. So I think staying on top of the cultures and sensitivities and making sure that we're drawing as many labs and staying as current as we can, and not just giving frivolous antibiotics, other medications that are causing more harm than good, I think are the best lessons that we can learn out of this epidemic here. So that's it for this week.